Good evening, everyone. A very warm welcome to you all. This is actually my second class on gastroenterology regarding MRCP Part 1 with you. Just to recapitulate, in the previous class, I started the gastroenterology chapter. We had a short introduction on the physiology of the GI tract, especially the important hormones and the important functions, the important role of the hormones in the GI tract. And I discussed some few questions that are commonly asked. After that, we discussed two esophageal disorders, achalasia cardia and gastroesophageal reflux disease. We had a brief discussion on these two diseases, and I also mentioned a few common questions that are asked. Today, what I'll do is I'll complete the other esophageal disorders, and I'll also be discussing a few stomach disorders as well. In my third class, I'll discuss pancreatic and intestinal disorders. And in my final class, we'll be discussing hepatic disorders. So I'll complete the gastroenterology in these 4 classes, hopefully. After today, when we finish 2 classes, I will discuss some questions, some actual questions that have come in the exams. So I'll start the presentation. If any of you have any questions, you can just write down in the chat or we can discuss at the end of the lecture as well. Okay, so I'll just continue with some more common esophageal disorders that are very commonly asked in the exam. I'll start with Barrett's esophagitis today. This is a condition where there is a change of the epithelium lining in the lower esophageal part, just 1 centimeter or more proximal to the lower esophageal junction. The normal squamous epithelium is replaced by columnar epithelium. This is called metaplasia. The most common cause of this metaplastic change is when the lower esophagus is constantly irritated due to reflux disease. As time goes by, metaplasia is replaced by dysplasia. The cells become abnormal, and in the long run, it may turn to a malignancy. So Barrett's esophagus is considered a pre-malignant condition. This is a very important point. This is based on this thing, we do the treatment or the follow-up of Barrett's esophagus patients. Here you can see the normal lower esophagus showing a pink coloration in the upper circle. And when the part of the esophagus becomes replaced by Barrett's esophagus, it has a whitish appearance, which we will see on endoscopy later on. So this is a typical appearance of the Barrett's esophagus. Here you can see the whitish areas showing Barrett's epithelium replacing the normal esophageal epithelium. The most common cause is the chronic inflammation that is due to chronic irritation due to gastroesophageal reflux disease. This is a common question that is asked. What is Barrett's esophagus? I was discussing the symptoms of Barrett's esophagus. There are no specific symptoms that will indicate that the patient has changed to Barrett's esophagus. You may have a patient having symptoms of long-time gastroesophageal reflux disease. And when you do an endoscopy, the typical appearance will give a suspicion that he has progressed to Barrett's esophagus. And ultimately, you have to do a biopsy to confirm the diagnosis. The confirmatory investigation is doing a biopsy. And the initial investigation is an endoscopy. Basically dysplasia. Like I told you, this is a condition where there is metaplasia of the epithelium. And there is dysplastic change, which is if on biopsy there is no evidence of dysplasia, that is the option. This is a very common question for Barrett's esophagus, the management. So when you have high dose proton pump inhibitor and follow-up. If you want to know details of the follow-up, you can remember that you do endoscopy with biopsy every 2 to 5 years. If less than 3 centimeter segment involved, endoscopy is done every 3 to 5 years. If more than 3 centimeters. So this is if there is no dysplasia. Number 2, if you have dysplasia, is it low grade or is it moderate to high grade? If it's low grade, you can repeat endoscopic biopsy in 6 months, every 6 months, and you have to do a radiofrequency ablation. This is the recommended treatment for low-grade dysplasia because it's a pre-malignant condition. If it's moderate to high-grade dysplasia, first choice is to do an ablation either endoscopic followed by radiofrequency ablation. And preferably, surgery is also done. If first line ablation is not possible, then second line you must do a surgery if it is moderate to high grade dysplasia. So you remember the treatment of Barrett's depending on dysplasia. So if there is no dysplasia, there is one treatment. If there is dysplasia, whether it's low grade or moderate to high grade, we treat accordingly. This is a summary of the treatment. This is one of the common questions asked from Barrett's esophagus, the treatment. So you remember whether there is dysplasia or not. If there is dysplasia, whether it's low grade or high grade, we treat and follow up respectively. And remember, Barrett's esophagus is a pre-malignant condition and it predisposes to esophageal cancer. As we'll see subsequently, esophageal cancer, two types, squamous cell carcinoma and adenocarcinoma. Barrett's esophagus is a risk for esophageal adenocarcinoma, not squamous cell carcinoma. This is also a question that may be asked in the exam. So that's about Barrett's esophagus. We'll come to another common topic that you have questions from in the exam, that is esophageal cancer. Like I said, esophageal cancer, there are two types, squamous cell cancer and adenocarcinoma. Squamous cell carcinoma is the worldwide common esophageal cancer, but in UK, the adenocarcinoma is more common, and it's more common in males. You need to know a bit difference of the two types because sometimes you get questions from here. The adenocarcinoma, it's common in the UK and it affects the lower 1/3 of the esophagus. The squamous cell carcinoma, it's worldwide more common than the adenocarcinoma, and it's more common in the upper 2/3 of the esophagus. These are the difference in the risk factors of the two different types of esophageal cancer. This is also a question you may get in the exam. The squamous cell carcinoma patients usually have a background of smoking, alcohol, or some sort of diet irregularity, either red meat consumption, zinc deficiency, low selenium levels. So when you have a background of smoking, alcohol, and some sort of diet irregularity, as I mentioned in the table, or patient having achalasia, Plummer-Vinson syndrome, or bisphosphonates, patient coming from this background and esophageal cancer, it's more likely to be squamous cell carcinoma. And in case of adenocarcinoma, just like I mentioned earlier, gastroesophageal reflux or Barrett's esophagus, a background of these two conditions definitely indicates adenocarcinoma. So you read your question carefully. You will have these risk factors as a background to give you a clue what type of cancer this patient is having. Sometimes H. pylori is also one of the options given in the STEM in the question. So H. pylori is not a risk factor for esophageal cancer. This is an important question. And the other risk factors I said, as I mentioned in the table. The symptoms that these patients usually have, the clues that will be given in your question is the patient is having dysphagia and weight loss. This dysphagia is initially worse on solids and later includes liquids. If you remember, we studied achalasia in the last class. That patient had dysphagia for a long time, and he had dysphagia to solids and liquids, both right from the start. That was a clue for achalasia. In esophageal cancer, the patient will usually have dysphagia with solids initially and later liquids. So that's an important clue to differentiate esophageal cancer and achalasia. Very commonly asked question, a very common approach to when you face questions regarding dysphagia or to differentiate esophageal cancer from achalasia, the pattern of the dysphagia. We'll talk a little more about dysphagia later on. I'll show you a table. So when you start with investigations of esophageal cancer, obviously the first test will be an endoscopy that will give you the presence of a mass in the esophagus, either the upper 2/3, lower 1/3. Then you do a biopsy, which will confirm the investigation, the diagnosis. A very common question regarding the staging of esophageal cancer you might get in the exam is how will you stage the cancer? To understand if there is any invasion within the ultrasound, you use a probe, doing an endoscopy and do an ultrasound. It will give you an exact uh, visualization whether the wall of the esophagus has been invaded. That's mural invasion. This is one common question that is usually asked. How do you understand if there is mural invasion or invasion within the wall of the esophagus in case of esophageal cancer? You do an endoscopic ultrasound. Very important question. To understand if there is any distant metastasis, obviously you do a CT scan of the chest, abdomen, pelvis, and you can also do a PET scan. So when you have distant metastasis, you need these investigations. If there is no distant metastasis, the only way to understand if there is any local tumor invasion, mural invasion, is an endoscopic ultrasound. This is an important question. How will you manage this patient? Obviously, it depends on the staging, whether it's confined to the mucosa, whether it's an early stage, whether it's locally advanced, whether it's a metastatic disease. So I've just summarized it in this table for you. If you have a superficial intramucosal esophageal cancer, you do an endoscopic resection and surveillance. If it's early stage, you do a surgery, esophagectomy. If it's locally advanced, that it's invaded the walls, you have to do a surgery with chemotherapy and chemoradiotherapy. If it's high risk, you do a combination of chemotherapy and radiotherapy. And for palliative care, you give opioids for pain relief, nifedipine, to relieve esophageal spasms. These are symptomatic treatments. So this is not a very common question because it's a surgical issue, but you should know the staging and the treatment options. So this is an important table for you. Questions are usually asked from this. I've summarized it for you here. The differences between the squamous cell carcinoma and the adenocarcinoma. Squamous cell carcinoma, more common worldwide. Adenocarcinoma, more common in the UK. The risk factors are different for both the cancers. As I said, smoking, alcohol, diet, achalasia, Plummer-Vinson are the risk factors, the background for giving you a clue for squamous cell carcinoma. And a background of long-time gastroesophageal reflux, Barrett's esophagus, is a clue that the patient might be having adenocarcinoma. And one occurs in the upper two-thirds, the other one in the lower one-third. And the squamous cell carcinoma more sensitive. Remember this table. This is a question that's a topic that's recently of interest in the exam, the pharyngeal pouch. This is a condition that you see in elderly males. This is a very important question, that what is the, in which group of people this pharyngeal pouch occurs? It occurs in elderly male patients. What it basically is, you can see in this diagram that I have shown for you, in the posterior pharyngeal wall, there is a potential space between the thyropharyngeus muscle and the cricopharyngeus muscle below. Thyropharyngeus above and the cricopharyngeus muscle below. This is called the Killian's dehiscence. This is a potential weak point here. So in elderly people, this becomes weak. Part of the pharynx or esophagus, the esophageal wall, it herniates through this space, as you can see in this picture. You can see this picture on the right, the thyropharyngeus muscle and the cricopharyngeus. This is a potential space where food can accumulate. The patient may have dysphagia, halitosis, and he may regurgitate, even have aspiration. And the problem with this thing is if you go and do an endoscopy, it can perforate the thing. It's a very weak thing. So it's a very sensitive issue. I'll just show you how to deal with this thing. So the pharyngeal pouch, it's a diverticulum through the Killian's dehiscence. The Killian's dehiscence is a triangular area between the two muscles that I showed you. The upper esophageal diverticulum is the common site. That's called the Zenker's diverticulum. So this is the pharyngeal pouch. The common symptoms that this patient has is dysphagia, regurgitation of food, sometimes even aspiration, coughing of food after food intake. And sometimes the patient has halitosis because of accumulation of food in that place. And there's a sign called Boyce sign. You have a swelling that is visible in the neck, and if you palpate it, you can feel a gargling going on in there. So this is called Boyce sign. So you will have an elderly male. Elderly male is having these features, and you suspect he or she might be having a pharyngeal pouch. So the best test to start with is a barium study, because if you do an endoscopy, it's risky. These pouches are very thin walled. The scope can perforate the uh, pouch. So you do a barium study, a pouch will be visible in the study. If an endoscopy is needed later to exclude any malignancy, you can do that safely. So this is the appearance of the barium swallow. You can see a pouch visible here on the swallow X-ray. So if it's in the upper part, a surgical treatment is preferable. And if it's in the middle or distal part, sometimes you can just follow up and not do a surgery. This is something you can remember. But the important thing is the investigation, the symptoms, and the location of the pharyngeal pouch. These are the common questions asked from here, actually. Been coming up in the exam is eosinophilic esophagitis. This thing was not known till very recently. It is a condition where the esophagus is infiltrated by eosinophils. And we know eosinophils are related to allergy. So it's an allergic inflammation of the esophagus. You have to confirm the diagnosis by taking biopsy. Only then we can confirm that it's an eosinophilic esophagitis, when you see the wall of the esophagus is infiltrated with eosinophils. So what is this condition? It's something that occurs due to an allergic reaction to some ingested food. When someone has an allergy, the chronic allergy, it leads to eosinophilic infiltration of the esophagus becomes inflamed. Patient has pain and dysphagia. So you will get a scenario case where a patient has a young patient. These patients are usually young. They have a background history of allergy, either food allergy or dermatitis, eczema or asthma. They will give you a background of these things and having symptoms. Intermittent dysphagia, not always. Sometimes there may even be food impaction in the pharynx or the esophagus. And very typically, these patients, they have no response to PPIs, proton pump inhibitors from GERD, which patients of GERD have case in your question, which will help you to identify that this is eosinophilic esophagitis. So as I said, the things that you have to do to confirm the diagnosis, you need to do an endoscopy, you need to do a biopsy. The biopsy will show more than 15 eosinophils per high power field. You will get a raised eosinophil count if you do a blood picture. And there may be a clue of an endoscopy being done sometime before and showing no evidence of gastroesophageal reflux. So these clues will help you diagnose. And the patient has had a trial of PPI with no response. So you will understand that this is a patient of eosinophilic esophagitis. Another important question is asked about the treatment. The main two modalities of treatment: number one, dietary modification. After you modify the diet, remove the food that the person is having allergy to, the second step is to use topical steroids, not oral steroids, topical steroids. You give a trial of topical steroids for 8 weeks and then oral steroids. So you read the question carefully. Are you being asked about the first step of treatment? Then that's dietary modification. Are you being asked the second step of treatment, that the patient is not responding to diet change? What's the second step? That is topical steroids, not oral steroids. So this is the common question asked from this eosinophilic esophagitis. There are a lot of details about the diet modification. You don't need to know all that. Third modality of treatment is esophageal dilatation. The majority of patients might need that at some point of treatment, because as you'll see complications later, a long time esophagitis, eosinophilic esophagitis can even lead to strictures. So you need esophageal dilatation as a treatment later on.